Welcome friends and young doctors and all those who are attending this webinar, webinar number 74, our critical care Sunday webinars. So today we have a very special speaker. Ma'am is Dr. Rakhi Maiwall. She is additional professor of hepatology and in charge of the liver intensive care unit at Institute of Liver and Biliary Sciences, Delhi. And she has a very long CV, so I was very confused in making the CV. So just to sum it up briefly, she has a special interest in critical care hepatology and especially in liver and renal dysfunction in the critically ill. And she is also the Vice Secretary of the International Club of ASCITES. She has more than 100 publications of original research work and 7 book chapters. That is just to sum it up briefly. And with that, ma'am, I will hand it over to you. The topic being chronic liver disease and very common complications of SBP, HRS, and ascites. So over to you, ma'am.
Thank you, Dr. Tapesh, for this very kind invitation. And it's an opportunity for me to speak in front of this wonderful audience. So I hope I'm audible and my slides are visible.
Yes, ma'am, audible. And
okay, so I have actually taken step by step. So we'll start from ascites, and from there we'll go to the acute kidney injury HRS, and then we'll finally wind it up by discussing about spontaneous bacterial peritonitis. So I'll talk about ascites first, and this is about what we'll talk about ascites. So when we talk about ascites in patients with chronic liver disease, what we need to understand is that it occurs in the natural progression of liver disease, and it's a sign of decompensation. So development of ascites is an ominous complication. And we can see here why this happens is pathophysiologically, when the patient is not having ascites, there is an appropriate renal sodium excretion. However, with time, because of the impairment and because of the sympathetic nervous system and increase in the plasma aldosterone, there is a progressive decline in the GFR, and therefore these patients start retaining sodium and subsequently the free water, and they start developing ascites. And with long-standing ascites will progress to refractory ascites, and patients with ascites, when they are started on diuretics and other problems, they start getting, again, because there is already a poor renal reserve which has started over here, they start getting episodes of hepatorenal syndrome. Now, what happens in these patients is that when you have a pre-ascitic stage, these patients have an activation of renin-angiotensin aldosterone system, the sympathetic nervous system, and the AVP, because here there is, in these patients, what we need to understand is that there is a normal effective blood volume, but with the progression of the liver disease, that is when there is a decline in the systemic vascular resistance, these patients become hyperdynamic. So there is planktonic arterial vasodilatation, and these actually the effective blood volume, the intravascular blood volume decreases. So what you see as ascites is not fluid over. These patients are usually having an effective hypovolemia on a background of a hyperdynamic circulatory state. And if you look at the liver pressures, the mean arterial and the hemodynamics in these patients, when there is a responsive ascites and this RF is a refractory ascites, with increase in the severity from the uncomplicated to complicated ascites, there's increase in the sinusoidal pressure. With time, there will be a decrease in the mean arterial pressure. So the severe is the liver disease, the more severe is the hemodynamic alterations, and this will impair the renal perfusion and will cause decline. Because of the decline in GFR, there will be constriction in the renal vascular bed. Now, this is the new pathophysiology of ascites. So apart from what we've already discussed, the portal hypertension driving the systemic and the circulatory dysfunction, the new hypothesis suggests that there is also the damage due to the damage-associated and pathogen-associated molecular patterns, and there is a gut dysbiosis. And why this has become very, very important is this adds an inflammatory component, and therefore comes the role of albumin in the management of ascites, which I'll be discussing in my subsequent slides. So when you see a patient of liver disease with ascites, we have to classify this patient, whether this patient has uncomplicated ascites or the patient has a complicated ascites or a refractory ascites. Now, uncomplicated ascites is usually ascites which is easy to mobilize. So patients with grade 2 ascites, grade 1 ascites are the patients who usually come under this uncomplicated ascites. They usually do not get infections, they do not get AKI, they are easily mobilized ascites. But refractory ascites is a more difficult to treat ascites because here the ascites cannot be mobilized, or the early recurrence of which, that is after therapeutic paracentesis, cannot be prevented by medical management. And we again have classification here. This can be diuretic resistant or diuretic intolerant. And what we see in our country is that we hardly see any patients with diuretic resistance, because here you have to go up to the spironolactone dose of 400 and furosemide to 160, which we are never able to do, because most of these patients will develop the complications. And most of the times, therefore, the refractory ascites that we are encountering in our Asian patients or Indian patients is the diuretic intolerant ascites. Let's go on to the management. So the first step when you assess a patient of liver disease with ascites, identify the etiology, because that will make a lot of impact on the ascites mobilization. If you're having an alcohol, you have to force on the abstinence. In a NASH-related CLD, when you have ascites, it is also important because these patients will have cardiovascular diseases. These may have chronic kidney disease, they may have thyroid dysfunction. So it's very, very important that you also look at the other organ involvement to say what is the exact cause of ascites and assess for sarcopenia. Despite being obese, these patients may be sarcopenic, and therefore they should not be put on the aggressive weight reduction protocols with ascites. Hepatitis B and C, it becomes important to start on the appropriate antivirals. Autoimmune, we will go with steroids if there is active cirrhosis, lesser grades of ascites where the patient is not advanced decompensated, and also in context of acute and chronic liver failure. For HbO2, we have to go with anticoagulants and other strategies. It's a very, very different etiology, and it is important therefore to pick this etiology of ascites, because again, you may make a lot of difference with the managing the etiology. Now, coming to the first step of management is the salt restriction. Now, when we as Indians, we consume around 10 to 12 grams of salt, and sodium restriction is what is recommended for patients who have developed ascites. We should not be giving prophylactic salt restriction. So if your patient doesn't have ascites, we should not be putting them on a salt restricted diet. But if your patient has ascites, the first part is to put them on a low salt, that is 2 grams, which has been proposed by the American Association. Varying from, you can also put on a modest salt restriction in the early stage of ascites. If you're not dealing with a very sick patient of grade 3 ascites, we can put them on a 4 to 6 grams of salt, because the stricter is the salt restriction, the better is the ascites control. But you have to see that the nutritional component is not compromised and not restricting their diet, because that will have an impact on the overall sarcopenia, which is very commonly seen. And I have put this in bold. There is no need of water restriction. This most of us are doing, and this should not be done in patients, because water restriction is associated with impairment of GFR and should be considered only on a case-to-case basis in patients with severe hypernatremia. And there also, the tolerance has not been proven, and the impact of water restriction has not been proven by any study. Now, the diuretic becomes a second line of management of these patients, and we know that there are different diuretics. And what we use commonly in our patients with cirrhosis is the loop diuretics. They act on the sodium potassium 2 chloride co-transporter in the ascending loop limb of the loop of Henle, and over here they improve the delivery of the sodium, and therefore there is increase in the water excretion. And there are potassium sparing diuretics, which are the main diuretics which are used. Now, how do we start the diuretics? So when you have a patient of grade 1 to 2 ascites, we have to start with spironolactone as the first. If the patient has significant pedal edema, you can combine it with the loop diuretic, because it has been shown that in a randomized controlled trial that giving spironolactone alone versus combining it is having equal benefit. And spironolactone usually causes modest diuresis, is free of all the loop diuretics cause a lot of complications. So it can be a better diuretic to start off in the early stage. And we can again assess our patients every 3 to 4 days, monitor them with the kidney function test and the weight charting, and see that because the peak effect of this drug will come in around 7 days time. So you step up your therapy every 7 days by 50 mg to be titrated up to 400, but usually in our practice, we've never gone above 200 mg per day. Now, the loop diuretics are also very, very essential. And what, again, with the availability is with us is about the furosemide or torsemide. The furosemide is the more popular one, which is used, and the mechanism starts at 30 minutes, it peaks at 1 to 2 hours and wears off by 3 to 4. And so it increases the sodium excretion, and therefore it can mobilize the ascites much faster. So if you have a severe grade of ascites, it is better to start off with a loop diuretic. And this is a randomized controlled trial, which I was talking about, is that whether you should be a combination therapy or a single agent. And it has been shown that if you combine it with the loop diuretics, you get an earlier onset of diuresis. You may reduce the incidence of hyperkalemia that is noted with spironolactone and other aldosterone antagonists. And you may also increase the efficacy by causing increased sodium delivery to the distal tubule. Now, they also head-to-head trial comparing whether we should be giving torsemide or furosemide in patients with cirrhosis and ascites. This is an old trial, and it has been shown clearly that the effects of torsemide were not different from furosemide in the first 6 hours. However, after 6 hours, you see that torsemide has a better excretion of sodium, and better free water excretion happens with torsemide. And the torsemide is basically when we give these strong loop diuretics. So it is good that you are able to achieve your sodium, your the excretion of water. You can mobilize the ascites, but at the cost of derangement of the hemodynamic and the hormonal pattern. So these loop diuretics will do a lot of harm to these patients, because in these studies, it has been nicely shown that they cause a decrease in the mean arterial pressure. The plasma renin activity is shown to increase, the plasma aldosterone increase, so they will negatively impact. So therefore, we have to use our diuretic therapy very, very judiciously in these patients. Now, monitoring these patients on loop diuretics, you can call them once you do the assessment of the response. Initial phases, when you're trying to mobilize, you should be calling them more frequently with the kidney function test, monitoring the electrolytes, uric acid, checking for symptoms of volume depletion, fatigue, cramps, and also monitoring the blood pressure and looking for orthostatic hypertension. And when do you start de-escalating? So it's not necessary once you have achieved your targeted response. So if the patient is having adverse effects, it's very clear that we need to stop or decrease the dose of the diuretic based on these complication that is encountered. If it's a serious complication, you will obviously also have to hospitalize and admit the patient. Even if you achieve a complete or a partial response, that is, then also it's important that you start coming down on the dose of diuretics to see that what is the best appropriate dose which can keep the patient ascites free. And the targets that we usually look for is about 2 kg weight loss with edema feet and about 0.5 kg without this. Now, this is a very interesting study which was published in Lancet. And this has changed the paradigm of management of refractory or the ascites, uncomplicated ascites in patients with decompensated cirrhosis, because the study was actually looking at the use of albumin not in a long-term fashion as a maintenance dose in patients who had uncomplicated ascites. So none of these patients had complicated ascites, and this trial, which was done in Italy, it was a multicentric trial. They showed that initially they gave 80 grams of albumin for 2 weeks, and subsequently they continued these patients on 40 grams of albumin for 18 months. And the standard medical treatment had received the diuretics and the salt restriction and the appropriate management of ascites. And what they showed here was there is a significant survival benefit if you combine your standard medical treatment with albumin. Now, they showed that there was also reduced needs of hospitalization, reduced incidence of TIPS or liver transplant in the population which got albumin. There was a decreased hazard, which was noted even on they did a competing risk analysis and showed that in all the parameters, there was a benefit of giving albumin. Now, there are other studies again, which have looked at different dosages because they had fixed a dose of 40 grams. So what dose of albumin is not known. But yes, adding a small dose of albumin, maybe 20 grams a week, may be very, very helpful in treating these patients with ascites. There's also a study which they subsequently published from the same study, that is the ANSWER trial, looking at what about should we be targeting serum albumin? And many of the clinicians just keep targeting the serum albumin. And what they showed here was these results were very interesting from the same study. They showed that the first thing is that there is no relationship between the baseline serum albumin and the mortality. Yes, when you give albumin to your patient, there's some patients who will respond. Each one will have an improvement in the serum albumin. Some will achieve may achieve normal values. And these are the patients who rapidly achieve the target values of serum albumin. These are the patients who actually do well subsequently. So the baseline serum albumin does predict mortality, but it is not that you should be targeting this albumin, and we really do not know what is the effective target for each patient. So each patient will have different targets. So it should be more or less individualized therapy rather than fixing the same dose of albumin for each patient. Now, we go from here to the refractory ascites, which I said it is a more difficult ascites to treat. But before we label these patients with refractory ascites, we have to see that we have checked for the salt compliance. Most important is many of the times these patients are not salt compliant. We have to see that they have been appropriately dosed with the diuretics. They're not having other etiologies of refractory ascites, other contributors. And you also have to rule out mixed ascites where there are two causes in the same patient, which have, and in India, tubercular peritonitis is very, very commonly encountered in these patients. So for checking the salt compliance, we can do a renal sodium excretion, or we can check that the excretion of salt in the sodium. You can do a urine spot sodium. And what has been seen is that if your patient is actually compliant and is not excreting more than 20 millimoles of sodium in the urine, this shows that there is diuretic resistance. So you check for the compliance. If the patient is compliant and the patient is not excreting salt, there is no point in increasing diuretics because they are not helping this patient and they may cause these patients to go into AKI. From here, we go in the refractory ascites. I would say that liver transplant is the best option because it will rapidly reverse the portal hypertension. And this is a very sick group of patients which will rapidly deteriorate, go into a lot of complications of SBP, HRS. They already have HRS too. So therefore, these patients should be counseled for a liver transplant. Now, what is the role of TIPS in these patients? Now, TIPS, I would suggest, has to be done early in the course of refractory ascites. So once your patient has passed the course and it is too advanced, we should never attempt TIPS. And I'll show the data because TIPS is definitely superior to a routine large volume paracentesis for the control of ascites. However, it adds by, because there you put a stent in the liver, and you can use different sizes of stents for these patients. And it is better in a sicker group of refractory ascites that we use a smaller size stent. And what has been shown is that the mechanism of action is the mobilization of ascites starts because it improves the urine sodium excretion. It improves the renal functions by improving the hemodynamics, reducing the portal pressures, reducing the plasma renin activity, aldosterone levels, norepinephrine concentration, and has also shown to improve with the increase in the energy intake, the frailty, sarcopenia, muscle mass has been shown to improve after TIPS. But again, it is important that if you see here, if your MEL scores are higher, then your reduction of mortality with TIPS may not be too effective. So the patients who have high MEL scores have high mortality at 2 years post-TIPS. So patients have to be appropriately selected. In refractory ascites, the MEL score may not give us the severity of the liver disease. So even with a MEL score of less than 10, the patient may have refractory ascites, and these are the patients who should be considered for TIPS. Because if you do TIPS in an advanced patient, you will get post-TIPS liver failure, which is a detrimental complication. And this is almost irreversible and associated with very high mortality. With time, you also get another very important complication, which is a post-TIPS encephalopathy. Usually it is seen in patients, in 1 in 3 patients who have TIPS. And if your patient already has a history of hepatic encephalopathy, the patient should not be given a TIPS. These are the risk factors you should not do in elderly patients above 65. Patients too advanced with low mean arterial pressure, high MEL score, HE, patients who have, and better not to choose a larger diameter of TIPS stent. You can also do a combination. This is a study which looked at combining large volume paracentesis with albumin versus TIPS, and they showed that TIPS performed better, but this was a retrospective analysis. Now, very quickly, I'll just finish this refractory ascites by discussing a dreaded complication. When you do repeated paracentesis, there is paracentesis-induced circulatory dysfunction, which is accompanied by low MAP, hyponatremia. Mortality is very high of this complication, and it is associated with significant renal dysfunction. And how do you prevent this? So you have to give albumin, almost 8 grams per liter. So if you are tapping around 6 liters, you have to replace it with 2 bottles of 20 grams of albumin, perform lower volumes at a time, because in sicker patients, the higher the volume you tap, the higher is the circulatory dysfunction. Better to discontinue the diuretics on the day of paracentesis and add vasoconstrictors. Midodrine is an orally available vasoconstrictor which can be added with albumin to these patients because it will maintain your mean arterial pressure and will take care of the hemodynamics. And we have shown in this randomized controlled trial that in patients with acute on chronic liver failure, that is those who are deeply jaundiced and coagulopathic, it is better to tap smaller volumes. So 3 to 4 liters, and even with 3 to 4 liters, better to replace them with an appropriate amount of albumin. Now, I'll not go into the details, but these are the studies on midodrine. Midodrine can be used alone or in combination with tolvaptan for mobilization of these difficult to treat refractory ascites. Okay, so this is a negative trial about albumin and midodrine, but this was not for patients with refractory ascites. But here, the dose of midodrine and albumin was not appropriate. I'll wind up by just talking about vaptans. Tolvaptan can be used for managing refractory ascites, particularly if they are hyponatremic. It will increase the free water excretion. And what has been suggested is that you should use, even with a low dose of 7.5 mg per day, you can achieve what you want to achieve your target. So it's not necessary that you go to very high dosages of 60 mg, which has been used in cardiac patients, because there is a black box warning for this drug. And in a meta-analysis, it has been shown that it also correlates with improved survival. The alpha pump is not available in our country, but again, it is an automated device which can be implanted. It's like a catheter, self-automated, and it will sense the ascites and it will mobilize the ascites to the bladder. Beta blockers is a contentious issue, whether we should be giving in refractory ascites or not. So there is a window hypothesis that in the later stage of ascites with patients with liver disease, the beta blockers are associated with more detrimental complications, and we should be stopping the beta blockers because they will cause decrease in your mean arterial pressure. And here is where they can compromise the renal perfusion. So we suggest that in patients who have low systolic BP, those who are already having infections, AKI, refractory ascites with low MAP, better not to give beta blockers. Nutrition and frailty is the backbone of refractory ascites patients, and we should not restrict exercise. These patients should be told to do moderate amounts of aerobic and resistance exercise. They should be put on a very good protein, and we should see that they do not go into malnutrition. Liver transplant, I already talked about. I would like to summarize the ascites management. We have to go with salt restriction, diuretics, monitor, dose the diuretics appropriately, counsel about the need of transplant in early stage. You should add regular albumin infusions. The data is very strong. Consider liver transplant early on in refractory ascites. Large volume paracentesis with adequate albumin replacement and tapping lower volumes in sicker patients. In the early stage, or if your patient is an appropriate candidate, as I showed you. If TIPS is not indicated, we can add the other drugs like midodrine. In hypovolemic hyponatremia, maybe tolvaptan, or you put your patients on a repeated TAP protocol, and there are other therapies which are being explored for the management of refractory ascites. So from here, we move on to the next part of my talk, that is about talking about AKI HRS in patients with cirrhosis. So we start here by outlining how do we assess the renal functions in these patients. I'll talk about the spectrum, and the diagnosis and subsequently the treatment. Now, when you see a patient with liver disease, the assessment of renal dysfunction begins whether this patient already has a chronic kidney disease, AKI, or has come with AKI on CKD, or is having an acute kidney disease, that is a prolonged AKI. So CKD again can be liver related, which we say is a functional CKD, or the previously called as HRS2, which is commonly seen in refractory ascites. It can be liver unrelated or structural AKI, as we can see in NASH patients who have diabetes, diabetes-associated intrinsic kidney diseases. All that has to be assessed. If the patient has AKI on a background of CKD, or the patient is having AKI alone, that carries a lot of difference in how you approach and manage these patients. When you see there is a spectrum of hepatorenal disorders, so if you have patients, you may have This is an old diagram where the older terminology is used. The HRS type 2 can have an AKI on top of it. You can have just AKI, or HRS1 on top of HRS type 2, or you may have HRS1 alone. In patients with CKD, again, you can have AKI, you can also have HRS. In HRS2 patients, again, you can have AKI, you can have HRS2 coexistent with the other forms of CKD, or you have HRS1 on HRS2. So it could be so complex. So therefore it becomes, and these are the revised definitions of HRS in patients with cirrhosis. So we have abandoned HRS1, and now HRS1 is called as what was called as a type 1 HRS is called as HRS AKI. HRS2 is now called as HRS NAKI. Again, it has been subdivided into HRS AKD and HRS CKD. Now, what is HRS AKI? Again, there is a lot of revisions in the diagnostic criteria. There is an abandonment of the absolute value of serum creatinine. We go by the AKI criteria. Urine output has again been incorporated in the latest guidelines, and you diagnose the AKI based on the baseline value of serum creatinine, which is the lowest value serum creatinine, which is available in the last 3 months. For AKD, we use the same definitions as has been proposed by the KDIGO group. And if your patient has a GFR reduction of less than 3 months, it is AKD. If it is more than 3 months in the so it is called as CKD. So the identification of duration of renal damage is very, very important. And again, I showed you that the different definitions for acute kidney injury, you have a timeline of 48 hours, increase in serum creatinine of 0.3 or a 50% from the baseline, and the time limit is 7 days, and urine output, which declines by 6 hours. And AKD and CKD, I've already discussed. Now, how do we identify chronic kidney disease? So I told you this is some data from kidney biopsies, a very difficult study. We know that we cannot do kidney biopsies in liver patients. And in this group, this was a French group, they showed that if you do kidney biopsies in these patients, most of these patients will have almost 75% had some form of the structural kidney damage. And they found that there were glomerular lesions in 82% and 50%, but all these patients had some form of abnormal urine microscopy or deranged creatinine meriting a kidney biopsy. Now, spectrum of CKD can be varied, and we talked about the CKD related to the viral causes, HRS NAKI, and again, hypertension, aging, diabetes, and obesity. So how do we assess CKD and how do we do that assessment? We can do it with the GFR equations. I know most of the centers do not have the measured, so we go by the GFR measuring estimated equations. Urine analysis is a very good test. Imaging can tell us if we see shrunken kidneys, we can find out whether the patient is, and kidney biopsy, even though gold standard, we cannot advocate to be done routinely in our patients. It's very, very important to look at the baseline value of serum creatinine when you're assessing the renal dysfunction in these patients. And this is how you grade it, because this is the most stable value of serum creatinine. And I would suggest that we should also look at the baseline urine analysis and GFR for all our patients. And we can then do an assessment. And if you have, and you're doing cystatin C, the cystatin C based equations can actually give us a better estimation in terms of patients who have cirrhosis with ascites, because they're a better marker of renal function. However, they usually give us an underestimated GFR. When you use the creatinine-based equation, the MDRD6 is the recommended one by the guidelines. It gives a small 10 to 15 ml per minute per meter square overestimation of the GFR. So with the cystatin C, you're underestimating. With the MDRD6, you're overestimating. But that's the best way to identify the GFR can tell us about the baseline renal reserve. Now we go on, if a patient has come to you with AKI, so how do we identify? So we use the definition after assessing the baseline serum creatinine. The patient has AKI, we have done an assessment for the duration of renal damage, and then we go to assess the status of the liver disease. So the status of liver disease is very, very important, and you can be seeing AKI in context of acute and chronic liver failure patients, which is a very different AKI. It's rapidly progressive. It is more likely due to jaundice and bulimic nephropathy, more likely to be inflammation driven. So this is a different AKI and the management and everything will be very different. But what we'll focus for our talk is the AKI, which we see more commonly in context of outpatients. Patients may have pre-renal. In the majority of times, it is due to diuretic use, volume losses, diarrhea, lactulose overuse. In patients, you have HRS AKI, you can have ATN, and critically ill, again, the spectrum will be different. And most often you can have PICD, you can have varicose bleed, you can have septic shock related AKI, you can have HRS1, or you can have ATN due to sepsis and inflammation. So the most important while you're seeing a patient with AKI is to identify the spectrum. Now, to be broadly saying, the spectrum of AKI can either be functional or structural. So what do we mean by functional? Functional is volume responsive AKI. So you see that the patient has responded to the volume or the fluid management. And once after 48 hours, if your patient does not respond, it becomes volume non-responsive AKI. And this functional AKIs classically is what we are calling as HRS AKI. The structural AKI, majority again would be volume non-responsive. And how do we differentiate? Because the HRS is difficult to differentiate from ATN. Both are volume non-responsive. The management is different for both the conditions. And therefore, good history and a clinical examination of nephrotoxic drugs, volume losses, sepsis. A urine microscopy could be very, very handy to look at the active sediment, urine albumin, protein to creatinine ratio, and we can also use the guidance of biomarkers. Urine microscopy can give us so much information. You can look at the color of the urine sediment, supernatant, pH, for looking at renal tubular acidosis. You can look at the epithelial cells. You can look at urosepsis. You can look at dysmorphic RBCs. You can look at the different kind of cars, which will be a roadmap of guiding us the kind and the damage to the kidneys. And we can get a lot of crystals, which again can tell us about the volume status of the patient, and obviously urine for albumin. These are pictures of patients with ATN and HRS. We can see it's a bland microscopy in HRS, while in ATN, it is, you can see muddy brown granular cast. The urine sodium can be fallacious because in context of patients who are volume depleted on diuretics, it may not be very helpful, but yes, this information could be very, very helpful. We can, now is the era of using biomarkers. We are using glycocalin-2 actively at our center in the ICU, and we have seen it works quite well because it's markedly high in patients with ATN. And this is the meta-analysis, which looked at all the biomarkers in patients with cirrhosis, and they found that the two promising ones were the urine interleukin-18 and glycocalin-2, which could tell us and differentiate ATN from other causes of AKI. After we have identified the spectrum, we need to stage the AKI. Now, the staging of severity is again very important, and I'll show you in the algorithm because how you start aggressively managing your AKI will also depends upon how severe is the AKI. So your patient has come with AKI 3. You will not be pumping in fluids. You will see that your patient is requiring an immediate dialysis. If your patient is in stage 1, you can still wait on, you can assess and monitor your patients for response. So the staging is very, very important. While you have staged, the next important step is to look at the course of AKI. Once you have started your medical management, how is the patient progressing? Is the patient progressing? Is the patient having regression? Or the patient is having a persistence? So that's the way to assess. And what has been shown, and this is the data for critically ill patients with cirrhosis. We analyzed 291 patients in the ICU. And what we showed here was that if you see patients with liver disease, almost 58, so 2/3 of these patients have some form of the AKI at presentation in the ICU, and 52% of these will have either a progression or persistence at day 7. And this progression or persistence of AKI is actually driven by severe systemic inflammation, the infections due to multi-drug resistant bacteria, elevated serum bilirubin, and the number of extrahepatic. So there is a crosstalk of kidneys, specifically in the context of critically ill patients. So the kidneys will move in the direction and they will also drive subsequent organ failures. And the progression is associated with worse outcomes in these patients. So how do we facilitate recovery? So this is the management algorithm proposed by the International Club of Ascites. This needs a lot of amendments, but this is what is the latest one where we say that if you have a stage 1 AKI, you can relax. Especially in an outpatient cirrhotic, you just look for the risk factors, withdraw the risk factors, correct the infections if present, do an appropriate volume expansion. However, if your patient has landed up in a stage 2 or 3 AKI, this is where you start expansion with volume, with albumin. The dose which is recommended is 1 gram per kg, but yes, we know that it is not necessary that we give 1 gram per kg. We can do individualized dose for these patients and look at the assessment of response. If the patient is volume non-responsive, we manage this patient as hepatorenal syndrome, which I'll be discussing in more detail. And you also need to look for specific phenotypes if the patient is not responding. But there are a lot of problems here because it does not specify which colloid, which crystalloid, now we know that there are dynamic indices which are being used, and we cannot say that we need to give the same dose for everybody. Should we be waiting for 48 hours in the ICU context? So we are monitoring the urine output, we are using the blood gas parameters. So it's not necessary that we keep waiting for 48 hours. So this can be okay for stable decompensated, but for unstable ACLF patients, there is a lot to be added in this algorithm. So let's discuss the management of pre-renal AKI. The choice of albumin can either be 5% if you're doing as a resuscitation if your patient is in shock, or you can use when there are lesser volumes required, you can use 20%. Crystalloids, we have shown data of plasma-lite can be added. It is a good crystalloid, and combination of albumin with crystalloid can also save cost, and it is better tolerated. And you can use the indices, the dynamic indices, and the more easy ones to use bedside is to target a good map, a urine output, and we can look at lactate clearances if the patient is admitted in the ICU. Now, this is the trial which we just published, and we looked at the role of 20% albumin versus plasma-lite, and we showed that even though albumin was better in improving renal functions, but it was associated with more pulmonary complications. It has been in patients with pneumonia and poor PF ratios, it is better not to use albumin, and plasma-lite is better in that context in AKI. 5% is definitely superior. This was another randomized control trial from our center where we showed that it is superior as compared to normal saline, and it improves the urine output and renal functions in these patients and achieves good MAP. So we have to be careful with 25% or 20% albumin. And I know we must be facing, I showed you data for refractory ascites as a long-term strategy, but in the critically ill patient, where there is impaired cardiopulmonary reserve, it is better to monitor the CVPs, the IVC diameter, because it has been shown that in the study that rapidly in giving albumin can cause problems in these patients. And subsequently, this was a randomized control trial of HRS patients. And this was again showing in patients who were decompensated and were requiring hospitalization cirrhotics. Again, similar data was shown of 20% albumin increasing the complications. Now, management of HRS AKI. So the diagnostic criteria I told about, you can use your urine output criteria. You have to look at 48 hours. There should not be any shock so that you're not dealing patients with ATN, and parenchymal liver disease, renal disease has to be ruled out. And these are the different drugs and trials which have been studied. But we know that terlipressin is the most popular one that can be used. And this is the latest trial of combining terlipressin and albumin for the treatment of type 1 hepatorenal syndrome. But they showed that the death due to respiratory disorders was very common, and terlipressin has a very higher risk of adverse effects and lung complications. How do we use terlipressin judiciously? It is important that you target the mean arterial pressure. And what I would suggest is that it is better in a sicker patient to start with norepinephrine and then add terlipressin to achieve the MAP, because if you're able to achieve the MAP, you're able to improve the renal perfusion. To reduce the adverse events, it has been shown again that it is better to give terlipressin not as boluses, but as a continuous infusion. So you have to administer continuous infusion. Don't start with very high dose. Start at 1 mg in 5% dextrose. This infusion has to be given. And it has been shown that the infusion will cause lesser adverse effects. The cost obviously is reduced and the efficacy is better. In context of acute on chronic liver failure, again, we have shown that terlipressin infusion is better than norepinephrine, but the problem is the adverse effects. So rapid development and rapid watch of adverse effects and how you use your terlipressin is very, very important, because even though you get very good reversal rates, but at the cost of life-threatening adverse effects. Non-HRS AKI, we have to look at nephrotoxicity as the main culprit, and this is the list of antibiotics where we have to be looking closely the GFR and looking at in patients where there is nephrotoxicity, we should stop these drugs. Hypervolemia has to be monitored, and we can do that with monitoring the intra-abdominal pressures, because that is a good way to decrease, and intra-abdominal hypertension can also compromise and cause impairment of renal perfusion. ATN patients, these patients, again, there is a dilemma of when to dialyze a cirrhotic patient with ATN. These are the absolute criteria where there is crystal clear and there we do not have any challenges, but it is the early phase where we actually are struggling to identify how to identify patients who would need dialysis. And the best way, and this is our data where we showed that you can use a combination of cystatin C and NGAL. And if your cystatin C and NGAL is above 2.9 or your NGAL is above 1500, this patient, you should not wait. If he's meeting relative criteria for dialysis, you can go for dialysis. Subsequent management of AKI, you have to go for a liver transplant timely, because AKI will cause subsequent development of AKI episodes, and this will lead to the development of chronic renal dysfunction. And again, I go back to the ANSWER study. So even if you want to prevent subsequent renal dysfunction and AKI episodes, it's better if the patient has recovered from AKI, you give these patients long-term albumin infusion. So this is the management and summary of the AKI. We have to look, do a good history, physical examination, remove all the offenders, do a staging, and do a individualized response-guided volume expansion. We can use albumin, add crystalloids. If the patient is improving, no further action. If the patient has AKI persistence or progression, I would recommend look for a urine microscopy and see, do a good cardiac echo, look for other confounders, rule out intrinsic kidney disease, and stratify whether the patient has a HRS or a non-HRS AKI. If the patient has HRS and it's a definite HRS, start your vasoconstrictors, target the MAP. Better to use a combination of norepinephrine and terlipressin. In non-HRS AKI, you can try and then again assess the response where there is an improbable, and you can use biomarkers. And if you achieve your response, you consider an early liver transplant, because HRS1 is associated with very, very high mortality. So we have to summarize here by saying that when you see a patient with AKI HRS, assess the renal reserve, use the AKI criteria. Urine analysis can be used if you're doing a catheterization, specifically in the intensive care units. Close monitoring of the course can improve the AKI outcomes. Assess the recovery and do a risk assessment. We can use biomarkers, but they are still experimental, and we do not have an ideal biomarker which can still replace a kidney biopsy. And management protocols for cirrhotics with background kidney disease have still not been defined. From here, I've moved to the last part, is about spontaneous bacterial peritonitis. And we know that when we compare patients with non-cirrhosis with infections, the mortality at 3 months has been reported in this particular study of less than 5%. But look at patients with cirrhosis. These patients have a higher predisposition to get bacterial infections. These are difficult to treat patients, and they are associated, infections are associated with very, very high mortality of around 50% of these patients will die in the next 3 months in the absence of a liver transplant. Now, spontaneous bacterial peritonitis is almost the second most common infection that we encounter in an intensive care unit. In the hospital-based, it is after the urinary tract infection, it is the second most common infection, seen in almost 10 to 30% of these patients, and the recurrence. So once your patient gets SBP, he gets episodic, again, gets future episodes, because these patients have continuous bacterial translocation. And again, you have different antibiotics. These were older protocols. These were older studies which looked at that these were the, most often these patients with cirrhosis have gram-negative organisms as the cause for SBP. Now, when we look at the pathogenesis of SBP, why do some patients develop SBP? It is because of the bacterial overgrowth. There is a large role of gut bacterial translocation, which happens in these patients, and there is an increased intestinal permeability. And obviously, there is a diseased liver sitting there. There is cirrhosis-associated immune dysfunction, a decreased capacity of the liver to clear these bacteria, and the LPS through the toll-like receptor 4. And because there is a decreased reticular endothelial function and Kupffer cell function, decreased phagocytosis, so these patients become at risk of getting these pathological bacterial translocation, which leads to the development of SBP. So when we look at the equation of the infection risk, it is dependent on the bacterial load and virulence, and obviously the host immunity. So all the factors are important, and that's how you would be treating your patient, because the resistant bacteria is associated with higher mortality. So what we are now seeing in our patients is that most of these patients will face the first line antibiotic therapy, specifically in India, where we have large amount of multi-drug resistant bacteria. So how do we identify which patients are having the risk factors of a difficult to treat SBP? So if your patient has a low acidic fluid protein, a poor liver function, a MEL score above 22, a past history of non-response of SBP, a platelet which is lower than 98,000, patients having SBP in context of GI bleed, having paralytic ileus, patients who have undergone invasive procedures again become dependent. So there are multiple factors, and these are the risk factors where the patients may get a difficult to treat SBP. Most of the times, a nosocomial SBP, a patient who has developed a recurrence or is having a Norflox or has developed a repeated episode or has failed the first line antibiotic management, is the one who will get difficult to treat SBP. So this is the data from our, this was a global study where we also had collated data, including data from PGI Chandigarh and many more centers in India. And what was very dismal here to see that MDR bacteria was seen in 34% of these patients, 8% had XDR organisms, and the highest was seen from our country, followed by Europe and America. And these are the types we see. Most often these patients had gram-negative organism, and this is how the spectrum has changed. So more often when you see sicker patients, you get MDR and XDR organisms, and this is what was seen in this study. And carbapenemase resistant Enterobacteriaceae were the most common, Acinetobacter, Pseudomonas, and VRE subsequently. And why this is important, because if you're not giving the first line antibiotic properly to these patients will quickly go on to the development of septic shock, they will require transfer to the ICU and have higher in-hospital mortality. So when you look at the factors, so these are the factors which we cannot correct. This is the severity of the patient, severity of the liver disease. But what we can make an effect here is the first line treatment. So if we're giving the right treatment after making a right assessment, we may improve the overall outcomes of these patients. So if you're dealing with a nosocomial SBP, you are most likely dealing in multi-drug resistant organisms. And this is where you have to start assessing for the risk factors, see if the patient is on norfloxacin. Here, there is a higher chance that this patient will have a vancomycin resistant or VRE in this setting. And you look for the risk factors, that is the patient, which I've already mentioned, sorry. So when you treat these patients with bacterial resistance, it is important that you use the appropriate line of management, because the resistance to the antibiotic therapy is associated with very high mortality in these patients. So once we have done that, I cannot go into the protocols of SBP management. We can have that if we have in the discussion for the lack of time. Now, when we look at the prophylaxis is required once your patient, we say primary prophylaxis is for prevention. So in a high-risk group where the patient has a more elevated creatinine of 1.2, has a serum sodium less than 130, or a child score C patient, or a bilirubin above 3, it is better to give a primary prophylaxis. A patient who is recovered will require indefinite prophylaxis. And in setting of acute gastrointestinal bleed patients, you should always be giving IV antibiotics to prevent these patients from SBP development. And on long-term, however, the studies have shown that if you give this norfloxacin prophylaxis or quinolone prophylaxis, there's a higher risk of development of antibiotic resistant strains. So this is what the data suggests, but still we have to give the prophylaxis to these patients. And in difficult to treat patients, what is suggested is that we really need much more sensitive tests to make a quicker diagnosis. We can use a different set of tests which can give us a rapid diagnosis of the organism. And this is how we can do what we can do clinically bedside every day is do a response assessment. So what has been suggested is that at 48 hours, if you do a response tab, so if you have clear clinical deterioration, then you do not need to wait for 48 hours. But if your patient is not showing any signs of clinical deterioration, routinely we should do a 48 hours response tab to document response and subsequently escalate the antibiotics if there is less than 25% reduction. And again, you should assess these patients at day 5 for a complete response. And in patients with cirrhosis, even though there are no prior markers, but yes, a combination of procalcitonin and CRP could be good ways to assess the severity of bacterial infection. So what has been suggested by different groups is that if you're dealing with a patient of SBP with severe sepsis or septic shock, it is better to give a carbapenem along with the glycopeptide, which includes tigecycline. You can use linezolid. In patients with less severe infections, we can start with carbapenem. In a difficult to treat SBP, never forget ruling out fungal peritonitis, and at day 2, we should always assess. I would like to summarize the third part by saying that SBP is a distinct entity in patients with cirrhosis, and again, seen in advanced stages, 50% of these patients will die in 3 to 6 months in the absence of a liver transplant. Antibiotic resistance is a menace, and we are dealing with it every day. Persistent SBP or poor response associated with poor outcomes, we need to have rapid diagnostic checks. We can combine biomarkers, and we can use the response tab to assess the treatment response. And I would like to thank you for your kind attention.
Thank you, ma'am, for an update on SBP, ASCITES, and HRS. Kindly stop your share screen, ma'am.
Okay, one second.
So that was a wonderful update. And let me see if there are any classes. So any questions? So please type your questions. Meanwhile, we'll just go through some points. Ma'am, the last thing, ma'am, about SBP, are you also seeing gram-positive in ILBS, or is this Western data? Because they have a much more incidence of gram-positive.
Yeah, we are not seeing. Our spectrum is clearly gram-negative. So in septic shock, we go with early colistin, specifically if you're dealing with the ACLF or advanced liver disease, because they rapidly go down. So it's better to de-escalate rather than escalating treatment in these patients.
Yes. So that's what I thought, ma'am, because the Western infections are much more gram-positive.
Yeah, they have reported a lot of. But I feel tigecycline is also a good choice drug if your patient is not in septic shock. So giving tigecycline, because it's some extended gram-negative, you're covering gram-positive also. So tigecycline is a good drug along with carbapenem, or maybe as a first-line therapy if a patient has come with organ dysfunctions but no shock. So that could be another option.
You can also consider ceftazidime, avibactam plus aztreonam. That is another option. Because
so what we are doing, because we have having very limited options, so we do not use ceftazidime in the ICU as the first line. So we save it for the second infection group. Otherwise, yes, this is a very, or we get the report of the, but that is a very, very good choice, which we can obviously, and ideally we should plan a head-to-head trial to see whether this is as effective as colistin.
Right, ma'am.
Because I feel the effectiveness is definitely not that much. You have to give it with colistin.
Yeah, colistin, only thing, ma'am, the kidney is also involved. So therein comes a problem.
Yeah, but if you give appropriate, colistin, that is the scare. So if we have, I think so for colistin, there are a lot of factors, and therefore the kidney management and how you monitor and manage the kidneys with colistin is also something which, if we're not very sure, we should not use.
Okay. So there's this question which has come up, ma'am. It says role of LOLA and branch chain amino acids.
Yes. So this is I would say that we're using LOLA, and we are doing randomized controlled trials at ILBS. So we are generating the evidence, but like whatever work has come out from Dr. Dashruti's group, from the animal data, there is a lot of data to suggest the role of branch chain amino acids in improving sarcopenia. So in refractory ascites, or wherever the patient has severe sarcopenia, you can add, there is a grade 3 evidence by the EASL that we can add branch chain amino acid or LOLA to these patients. For hepatic encephalopathy, there is again some data as a secondary for the management once the patient has failed in the acute setting and chronic. But again, the evidence is not very strong. There is no randomized controlled trial, and it's a very weak evidence. But yes, based on the clinical and preclinical data, we do feel that it is benefit.
Thank you, ma'am. So we'll just run through some points which would be of interest to our intensivists. So just starting with albumin, the way we understand albumin is there are three main indications. One is HRS, SBP, and large volume paracentesis. And of course, there's a soft indication in septic shock, that if you're using a lot of NS or plasmalite, and if it's not responding, then you can use albumin. That is just the sepsis 4 guidelines to be applied to cirrhotic patients. So are there any other indications in the ICU for the use of albumin, accepted indications?
So, like I said, the guidelines are for non-cirrhotics. So there are no particular trials done in patients with liver disease. So what we do in our patients is we never give them alone crystalloids because they will go into third space. So we definitely put some albumin, as if the requirement of the resuscitation fluid is much more, we combine 5% with the crystalloids. That's how we do. And we give more crystalloids. So that ways we are giving crystalloids, but we are keeping albumin there to expand the interstitial, because the fluid should not go into the interstitial space. And like you said, that we have, from our group, we have published 2 papers on cirrhosis now to say that albumin performs better. But yes, it is not that we need to have trials again combining albumin with crystalloid, because that is the current practice. For 20% albumin, the expanding indications has been in context of what I said is the long-term usage to prevent, to mobilize the ascites, to increase and to improve refractory ascites, to patients prevent renal dysfunction for HRS2 patients, HRS-NAKI patients, preventing renal dysfunction, and in context of hepatic hydrothoraces in the ICU. So that is another indication. And when we do dialysis, so to prevent intradialytic hypertension, there is another, because this is not there in the guidelines, but that's where we use albumin, a small dose, 25%, just to expand the intravascular compartment with dialysis.
Yeah, so okay, ma'am. So coming to albumin as such, 5% and 20%. So where essential differences? I mean, if you give albumin at a fixed grams per hour, it is the infusion rate of albumin. So there should be no difference, right? That is the way we understand it. If you give 20% fast, it is hyperoncotic, it will draw in fluid, and that is what probably leads to more pulmonary complications.
Yeah.
But to give albumin, slowly 20% and 5% at the same rate of albumin per hour infusion, it should be different. I mean, I want your take.
So therefore, the
20% and 5%.
Yeah, totally agreed. So therefore, for resuscitation, when you use larger volumes, there 20% may not be good. 5%, even if I give boluses to my patient, they will tolerate. So a larger volume of 5% will still be tolerated by the cirrhotic, but the larger volume of a 20% albumin given rapidly to expand, to maintain the MAP is not tolerated. They go into pulmonary complication. That is what the message was. So for resuscitation, where the larger volumes are required, we prefer 5%.
Right. So actually, if you read the treatment of HRS or SBP or even LVP, so for HRS they recommend 20%. Similarly, for LVP they recommend 20%. But for this thing, your SBP is just 1 gram per 1.5 gram first day and 1 gram per kg the third day. So there is a distinction between 20% and 5% made out in the literature.
But that doesn't work. I don't know whether you're practicing giving that protocol. We have published several protocols. Now we are done back-to-back RCTs showing that 1.5 gram per kg, that dose of which has been, because these were very old studies and subsequently this has been put into guidelines. But if you ask any, we are not going with those guidelines. What we are doing is we are giving individualized dosages. So SBP in the ICU, I will manage this patient differently. SBP patient in the ward who's not in shock, yes, you can give that much of albumin. But 1.5 gram per kg to a patient who's admitted to the ICU with all the lung and other complications, capillary leak, they do not tolerate that 1.5 gram per kg protocol.
So, ma'am, then generally for SBP, how much albumin should be used in our patients? It's not affordable also. So what kind of a recommendation?
Yeah, so what they have written 1.5 gram, it is not required. At the most 2 bottles, maybe 25 grams is enough. 40 grams or 50 grams of albumin is also enough. That is what we see.
Right. So, ma'am, then moving on to intravenous fluids. So intravenous fluids, of course, if the patient is in hypotension, the fluid of choice is crystalloid, normal saline or plasmolite if you're giving a lot of this thing. But what about maintenance fluid in patients of ascites, because you want to restrict sodium, so you would not like to give too much normal saline. If
Yeah.
giving enteral feeds, fine, you can give a low salt, and that would take care of the volume. But sometimes you cannot give enteral feed, you have to put them on maintenance fluids. So the amount and the kind of fluid you would like to give for replacement.
Yes, this is absolutely, this is what you're saying is absolutely right. So we have to be very, very careful while we have come out of that, the de-escalation protocols and the management, the patient while we are maintaining the fluid. So what we do in our ICU, I would say, we give 25% albumin in that set. And at the most, again, 25%, either 25 grams or 50 grams based on the need of the patient. So if they're requiring frequent paracentesis or thoracentesis, then maybe we give extra. Otherwise, maintenance is just 25 grams of albumin, which we give these patients, and rest we maintain enterally or whatever way they want to.
Okay. So then, ma'am, moving on to the use of vasopressors in septic shock in these patients of cirrhosis. So the first line is norepinephrine. And do you use a vasopressin or terlipressin also after that if the doses are going high? Or which one, I mean, would you like to recommend?
Yeah, so if you ask me, I would say that even though there is no head-to-head trial, but vasopressin is better drug, safer drug, and especially in when your patient has a higher requirement of norepinephrine is increasing. So you have both choices. You have terlipressin, you have vasopressin. So if the shock is much severe, I will choose vasopressin. I will not use terlipressin because these patients have microcirculatory failure. They quickly go on to develop very severe side effects. And if in the setting where I am seeing that my patient is non-oliguric, if the patient is already in ATN, I will never use terlipressin. If my patient is non-oliguric, has some functional component of HRS, is in the declining doses of norepinephrine, means reversing shock, there I will start adding terlipressin, improving the hemodynamics and also that setting, it would be very, very helpful. In early phases of septic shock, yes, a very low dose of 0.5 to 1 milligram can do the whatever effects we want, we can achieve with that.
Right. So then coming to the MAP, MAP is generally low in these patients of cirrhosis, right, ma'am? So what kind of MAP should we target? In general patients, we target a MAP of 65 in septic shock. But is it different here or like what? Often literature says go for a MAP which is 10 more than what it was at baseline. So what MAP would you advise?
So I have actually finished the trial of 150 patients and we presented in this ASLD meeting, and I would share with you the results. So what we found was very interesting. 75 patients where we targeted the MAP of 60 to 65, and 75 patients we randomized, they were targeted MAP of 80 to 85. So when we did an intention to treat analysis, there was no difference in the two groups. But the difference was that almost 1 in 3 patients, when you are targeting a higher MAP, they required discontinuation because of side effects of vasopressors. So then we found on the per protocol where we were able to target patients when you give vasopressor. You start these patients on vasopressor, there is a group which will start like volume responsiveness. The same is vasopressor responsiveness. So we found that the patients who started to respond, they achieved the MAP, we gave the vasopressor, they were having improvement in all outcomes, renal outcomes, everything. But the way we are pumping in vasopressors to target a MAP, that should not be done. So because that will cause problems to your patient. So again, I would suggest that we should go for, again, assessment of the response rather than, so for each patient, the response should be personalized and we should assess. The second important thing which we found was if you're dialyzing your patient, never keep a low MAP. In that set, obviously your MAP has to be 80 to 85 if you're dialyzing, doing SLED or CRRT, because the hypertension you will not be achieving a good dialysis response. And these patients will quickly go on to hypertension if you start them dialyzing at a lower MAP. So that is what we found.
Right. So another thing, a simple question, does the blood pressure MAP or the blood pressure correlate with the degree of cirrhosis, or is it variable?
Yes, it definitely correlates with the degree. When your patient advances, the higher is the severity of cirrhosis, the lower is the mean arterial pressure, and we start seeing diastolic hypertension in these patients. So that is a very important surrogate of showing severe systemic vasodilatation. So even if in your outpatient we are seeing a low diastolic BP, it's better to give midodrine or start working on that, because that is impairing the organ perfusion.
Right, ma'am. Then, ma'am, moving on to just HRS and AKI. So, when do you actually say that your treatment is failing in HRS AKI? And when do you consider RRT, or no, or if, the patient is not doing well? So, what about the treatment part? When do you stop it, or when do you escalate terlipressin? And you talked about the terlipressin infusion. So, how much infusion to give with terlipressin? Just talk about that a bit.
Terlipressin infusion, we usually start. Again, like I said about how we do that, we assess for the initial response. So we give a 0.5 mg dose initially before we start the infusion. We see the responsiveness of the patient, whether the patient responded with the MAP. If yes, we start a 1 mg infusion continuous to these patients. So that's how we give terlipressin in shock patients. In HRS patients where there is limited shock, obviously we should go for terlipressin infusion. In patients who are not in severe degrees of shock. So there, obviously, we should go with terlipressin infusion. Again, starting with a lower dose is better and then escalating it. At the max, I feel we have gone up to a maximum dose of 3 mg in our ICU. They never require more than that. And most of them will achieve the response in 2 mg continuous infusion. Then how do we monitor these patients is by...
And this 2 mg has to cover how much time? 2 mg, 3
2 mg over 24 hours.
Right. Okay.
So 24 hours to continuous infusion, and combine it with norepinephrine. So whatever MAP we want to target, we can increase. We keep the terlipressin infusion constant. We can monitor the renal indices bedside. We look at the blood gases. We start looking at the urine output. So those two factors and the improvement in MAP. This will tell us that the kidneys have started to respond.
And when do you say the treatment is not working, ma'am? Because a lot of them don't respond also.
Yeah.
Terlipressin at day 3. So, like what?
So for HRS AKI, I would suggest that we should not rush in for a dialysis at all. We should wait. These patients will not do well with dialysis. So therefore, that discrimination of ATN and HRS is very, very important in the ICU. In an ATN patient, we should not waste time, because then you will lose the window of dialyzing the patient. So ATN, if we have recognized it well, HRS, we should defer dialysis as long as possible. Wait till your patient meets absolute criteria. For ATN, yes, relative criteria, and we should see that the patient is not getting better. We should dialyze before the patient goes into severe shock. The other thing is looking at ACLF. I don't know whether, because I didn't want to confuse, there are so many definitions of ACLF. So acutely decompensated cirrhotic versus a patient with ACLF. So ACLF patients, we have different protocols. We very quickly start CRRT in these patients, and we've seen very good outcomes. So the moment they start getting mild metabolic acidosis, they're still making good urine. We start them on CRRT, and we see very good outcome, because there it is like removing the cytokines. So it works quite well in that setting.
Right. Great. So there's also a subset of AKI patients who respond to diuretics, ma'am, like they have CHF and all because of cardiomyopathy, alcoholic cardiomyopathy, portopulmonary hypertension and all that. So that is also important. We need to assess, or we should not rush in fluids to all the patients with AKI. Some of them may respond just to diuretics and maybe because of CHF.
Yes. So there are a lot of instances where we have to give diuretics, but IV diuretics, I would prefer a non-invasive ventilation or something, giving PEEP if they have hydrothoracis, just to assess the kidney function. Because as I said, most of the times these patients are effectively hypovolemic. So I would try and see the volume status. I would judiciously use diuretics if the patient I see is in the recovering phase and the kidneys are recovering, the creatinine is recovering, his patient is fluid overloaded. Obviously there, IV diuretics every day are very, very helpful to mobilize the extra fluid along with albumin.
So then moving on to, ma'am, assessing volume responsiveness. So what kind of parameters are you using, ma'am? Because the IVC is difficult to use. It gets compressed by the ascitic fluid, and the CVP also is a little bit falsely elevated, and CVP as such is not a very good marker. CVP has a lot of problems. So what kind of fluid assessment markers are you using, ma'am?
So fluid assessment, we use a combination of parameters. So we do the IVC. If the IVC is high and is not whatever measurement of the IVC we are getting. So if the IVC is supposing 15, we can give fluid. But supposing I have a patient who has IVC of 20 and is not showing any variation, then I would go by the giving a mini fluid bolus of a colloid, a 5% albumin, looking at the hemodynamic and looking at the response of the patient to that, and then decide whether the patient is fluid responsive or not. Wherever possible, we also use the flow tracks and other indices but not for every patient. We cannot use for that every patient, but most of these patients, we check their own response. They're based on the lactate clearances, based on the MAP improvement and the urine output, acid-base balance getting better. So we give mini fluid boluses and then see. And obviously keep other surrogate markers, looking at X-rays and those lung ultrasounds to look at.
Do you use the PLR also, ma'am, in these patients? Does it work?
No, we don't have those beds, so it is very, very difficult to do.
Right. I understand. Then, ma'am, what about the side effects of terlipressin? There are a lot of side effects, especially digital ischemia, but there are other side effects mentioned, like they can cause intracranial hemorrhage and respiratory failure, bronchospasm. So you must be using a lot of. So you see all these intracranial.
Yeah, we see. That's why I'm saying I have actually put one person on the job for looking at terlipressin side effects daily and reporting to me on the rounds. Yeah. If a patient is on terlipressin, every day there is a checklist, and we see for all possible. And you will see that one other very important. You will see these patients start getting on their chest purpura fulminans, so microvascular. They get these bleeding complications. They get this alveolar hemorrhages they can get. And initially, when we, like over the years, we have developed so much, but initially we also used to have cardiac arrhythmias. We have lost patients of MI also. They will go into MI, and that's how we have come down on the protocols, dosages, choice of patients. So a lot of.
Right. Then just the last few things, ma'am, we'd like to go through. You had mentioned about the biomarkers for ATN. So can you just talk a little about that, ma'am? Biomarkers for cirrhosis and AKI?
Yeah. So if I say I have to use biomarkers in cirrhosis, I will recommend 2 biomarkers in context of patients when we are dealing in the ICU. Cystatin C is not that useful. NGAL is very useful. NGAL also is influenced by so many factors, but if you see a very high NGAL, you know you're dealing with ATN. If your NGAL is low, you can still think that, okay, this could be HRS and I could wait on the dialysis. That's why I said that we should not dialyze HRS because they don't do well with dialysis. The second is where NGAL could be very, very helpful is like in ACLF patients. We are dealing with we have some new data. We have shown that coulimic nephropathy, the jaundice mediated nephropathy, is very different from ATN. ATN patients don't recover their AKI. Coulimic nephropathy patients do recover because they were having more repair markers. So all that data is there, but to say that NGAL in that context can tell me in a jaundiced patient of ACLF, this is ATN versus this is coulimic nephropathy, where the outcomes are better with plasma exchange and CRRT. But ATN do not respond. In the outpatient setting, when I'm dealing with a decompensated cirrhotic, cystatin C I find very, very helpful for me to understand in a refractory ascites patient where the creatinine never gets increased. So you may look at urea as a marker, very easy to see urea. And if at all you have availability of cystatin C can tell us that the kidneys are badly impaired and you should not be giving diuretics to these patients.
Okay, right. So then about the diagnosis of sepsis, the biomarkers that we have, TLC, CRP, ProCal, which you normally use, are difficult to use in these cirrhotic patients. One
is absolutely right.
Or normal because of hypersplenism, and little bit elevation of CRP is normal. ProCal also gets elevated a little bit, and they don't follow the normal kinetics.
Yes.
It comes from the liver. ProCal is already elevated to some extent. So how do you use these markers, or how do you make the diagnosis, ma'am? Of course, there's a clinical aspect. You look at the patient, he has fever, but you need some markers sometimes. So
so when I use ProCal, actually we are doing daily ProCals in our ICU. And how I do look at ProCal is 2 things which I have found in cirrhosis patients. One is a low ProCal. When you're thinking of sepsis, patient has clear evidence based on infiltrates in the lung, may have SBP, but the procal is normal. These patients, one is obviously you will think of other causes like fungal and other causes of sepsis, but what we see in bacterial sepsis is that these patients have poor outcomes. Patients whose procal is rising, so where rising, then we look at the titers. If the patient has started to decline the procal, we are happy that our response, our therapies are working. Or when we are suspecting and we do procal, it doesn't rise, or even if it doesn't rise, we go with cultures, we go by clinical assessment. So if the patient has increase in lactate, has dropped his MAP, a cirrhotic patient, even encephalopathy could be a sign of sepsis. So we look at subtle signs and we correlate it to biomarkers, but yes, we cannot go. And I think so coagulation assessment is a very, very important feature which should be assessed, monitoring the INRs and the platelet counts, because that can also tell us that the patient is getting sepsis.
Right, ma'am. So I think just the last few questions. Then, ma'am, in the patients who come with ascites and who are bad, when should we not use diuretics? You know, one of a few situations like a sodium less than 125, etc., are mentioned that you should not use diuretics. So when should we not use diuretics in these patients who are in the ICU and who have a
ICU?
Yeah.
Yeah. So diuretics in the ICU, I would suggest better to use a short dose of tolvaptan or these drugs and use terlipressin to improve the urine sodium excretion. So if you want to mobilize the fluid, we have to use more vasoconstrictors or drugs, but diuretics can be harmful, especially if the patient is having renal dysfunction, AKI, or some acid. If the patient is preserved renal functions, yes, we can use IV loop diuretics, and subsequently we can start monitoring their weights and monitor the kidney function. But in ICU, I would, in the sepsis context, I said that diuretics, I know other groups have different experiences. They give IV infusions, but we do not do that.
Right. So just a last question, ma'am, about a very simple question about the paracentesis. So for obviously a lot of these patients have thrombocytopenia and the INR is increased and TEG is not available everywhere. I mean, most of the places ICUs don't have TEG. So what are the recommendations for transfusing, ma'am, before a paracentesis, especially, you know, large volume paracentesis and all?
Yeah, this is a very, very important question. So how we do it is like what is recommended also. See, there are no guidelines. Ideally, we should not be correcting. But when we are dealing with a patient with advanced liver failure, who's severely coagulopathic, who's in uremia, who's in sepsis, there obviously we should correct. We always correct in our ICU. We go with Rotem and we do that. But if I have to do that repeatedly, so what we do in our ICU is we put a pigtail one time correcting, then putting a pigtail, clamping it until the patient recovers. We keep that tube in situ so that daily he's not requiring that prolonged coagulopathic correction. So we can open whenever he requires a ascitic tap, you can open that tube. And then once you are shifting this patient out from the ICU, you can remove the tube based on the necessity if it is not required. Same for thoracic tubes. So if you have a hepatic hydrothorax and you know that every day there will be a requirement, so you can go with one-time correction and giving, putting these tubes, which are very helpful. But we should correct, definitely. We should not do therapeutic.
So what kind of numbers are we seeing, ma'am, when we correct? What kind of numbers? What kind of numbers? Platelet numbers and INR?
No, so I said we are going with the Rotem.
No, the taken Rotem is not.
Yeah, if you're not, then I would say that at least one, supposing the platelet is around 50,000. You don't need to correct that.
Yeah.
But if it is, so you may just give one SDP just to give some support, some circulating platelets.
Okay.
But if your number is very poor, then obviously you should give at least RDP. Sorry, I said SDP. You can go with RDP. And if your number is too low, then obviously we have to give at least one SDP. We give FFPs and cryo. Cryo is something which we give quite frequently and most of the times, and Tranexa, because fibrinolysis is very common in these patients. So we do give them tranexamic acid, and that's very helpful.
Let me see if there are any questions, ma'am. Thank you for the
Thank you,
ma'am. That was very encouraging and very enlightening. So
thank you, sir.
Portal vein thrombosis is a question, ma'am. Portal vein thrombosis treatment.
Okay. So portal vein thrombosis, we have to see whether this is whether it is acute portal vein thrombosis or a chronic portal vein thrombosis. In acute portal vein thrombosis, there is no doubt that we have to be aggressively treating the acute portal vein thrombosis with anticoagulation, whatever measures. TIPS can also be done, and you have to do the thrombolytic therapies and other therapies like you manage the routine. But when you deal with the chronic portal vein thrombosis, again, there could be a cavernoma where it is a very established cavernoma there. You can have a partial portal vein, which is there chronically thrombosed. You may have a complete portal vein thrombosis. So all that setting, the data suggests that these patients, if they have no contraindications for anticoagulation, because this is associated with bad outcomes, poor liver function and decline in the liver function, so it has to be treated. The only problem is most of these patients will have thrombocytopenia. So if your patient is not thrombocytopenic, we screen for the viruses, we ligate the viruses, and we start them in oral anticoagulants. The newer oral anticoagulants also, now we have experience with dabigatran, it works quite well. Or we can go with the Clexane till the patient is able to adjust, and then we can switch to dabigatran. The other context is if your patient is thrombocytopenic, and if the patient is a candidate, TIPS works quite well in these patients. And I'm talking about portal vein thrombosis, not due to other factors when we have done all the assessment and we've ruled out all other possible hyperprothrombotic states. And we are saying a liver disease related, poor flow related portal vein thrombosis. In that context, whatever management, TIPS is an emerging treatment, we can do TIPS. And what is recommended before transplant, people say that the guidelines recommend that these patients should be put on anticoagulants.
So thank you, ma'am. Any other questions? We'll just wait for 2 minutes if there are any other questions. So I think that's about it, ma'am. So thank you very much, and hope to see you again, ma'am. Thank you very much.
Okay, thank you, Dr.
And thank you very much.
Thank you.